Good morning. I'm Harminder Singh from the University of Manitoba, from the Departments of Internal Medicine and Community Health Sciences. I'm going to talk about our study, which is pathological reassessment of hyperplastic colon polyps. In a citywide pathology practice, implications for polyp surveillance and recommendations. This study was performed at the University of Manitoba. There are 6 hospitals in the city, and in this study the pathological reporting from all the sites was assessed. Colonoscopy is one of the recommended methods for screening for colorectal cancer. Lately, there have been several studies published, including that by ourselves, which have suggested that a significant number of colon cancers may be diagnosed soon after colonoscopy. These cancers, also referred to as interval cancers, raise issues on the effectiveness of colonoscopy in reducing overall burden of colorectal cancer. There are several potential issues. These cancers occurring soon after colonoscopy may be because the lesions were not seen on colonoscopy by the endoscopist. These could also be because of different biology of these lesions. It is also possible it's a combination of these factors. Serrated colon polyps are a category of lesions which have gained increasing importance over the last number of years, as they are thought to be responsible for at least some of these cancers which are occurring soon after colonoscopy. One of the issues though with the serrated colon polyps is that the classification and reporting has varied in different pathology laboratories. Over the last several years, the classification has become more standardized. Hyperplastic polyps on their own seem to be benign, and there is no established risk of increased risk of colon cancer occurring after hyperplastic polyps on their own. However, the subcategory of sessile serrated colon polyps are thought to be the ones which may be important precursors for some of the colon cancers occurring, particularly those after colonoscopy. In this particular study, we were interested in looking at the lesions which were diagnosed as hyperplastic polyp in the past in a recent year, and then seeing if on reassessment some of them would have been better classified as sessile serrated adenomas. We also wanted to look for predictors of reclassifying previously diagnosed hyperplastic polyps as SSAs. There has been limited prior work done on looking at the predictors of reclassification. What we found was 20% of the lesions which were classified as hyperplastic polyps and were more than 5 mm in size. On reassessment, 20% would be reclassified as sessile serrated adenomas. This reclassification was being done by 2 pathologists who were not aware of the size or the site of the previously reported hyperplastic polyps. We also found approximately again 20% of the lesions in the right colon, previously called hyperplastic, would be reclassified as sessile serrated adenomas on reassessment. Thereby, we found approximately a 4 times higher risk when the lesions are in right colon or larger than 5 mm. We believe our study suggests that not just the histology of these sessile colon polyps should be considered in deciding future follow-up, but also the site, whether the lesion is right or left colon, and what is the size of the lesion should also be considered. This, until there is a bit more standardization uh, in the actual reporting in routine clinical practice. We hope such a practice would lead to reduction in the risk of interval cancers. The number of these lesions is small, so this is not likely going to increase the burden of colonoscopies. Um, we do hope this overall will lead to reduction in the incidence and burden of colon cancer. Of course, the issues of the missed lesions is also an important issue which needs to be looked into, and many groups are looking into it as to what can prompt endoscopists to be able to pick up the lesions and less likely thereby of lesions being diagnosed soon after colonoscopy. Thank you for listening to me. Bye.